We are so excited today. I think it's like 1,700 people actually signed up for this webinar. And there is no reason why you shouldn't, because what we are trying to do today is really to translate the 2025 UN political declaration and commitments into action for circulatory health. My name is Dr. Bente Mikkelsen. I'm the advocacy chairperson for the World Heart Federation. Some of you might remember me from the days as NCD director at WHO, where I stepped down in 2024. This webinar is co-hosted by several very important organizations in this space. The first and foremost is the International Society of Nephrology, the International Diabetes Federation, and the World Heart Federation, and on behalf of the Global Coalition for Circulatory Health. This joint efforts reflects our shared recognition for circulatory conditions, especially cardiovascular disease, diabetes, and kidney disease. And you probably know we even had a separate kidney resolution for the World Health Assembly last year. And all of these are deeply interconnected, and that meaningful progress really depends on coordinated system-wide action. So the fourth political declaration on NCD was adopted in September 2025, and it represents a renewed commitment for prevention, early detection, treatment, and care across the life course, with a strong focus on integrated and people-centered intervention. In particular, it recognizes that circulatory conditions remain a leading cause of NCD-related morbidity and deaths. You probably know that 38% of all global deaths is due to these diseases. So what matters is how these commitments are translated, because of course a political declaration doesn't really help if we don't do the thing as well. And we want to save life. So this is what the next 90 minutes is about. We will explore how governments have committed and also examine what national implementation could look like, and also propose practical actions to improve the implementation. So we all feel, I think, and I hope all of you online as well, we feel the urgency. So our webinar is about turning the ambitions into deliverability and accountability. And to manage that, we need to work together, all of the people who have signed up, and of course, many, many more. It's now my huge pleasure to welcome, I would say, both a professional and also my friend, Dr. Professor Marcello Tonelli, which I had the pleasure of working with in Geneva several years ago. And he will speak on behalf of the co-host and partner in the Global Coalition for Circulatory Health. So Professor Marcello Tonelli is the president of the International Society of Nephrology and a leading global expert in chronic kidney disease and noncommunicable diseases. He is widely recognized for his contributions to advancing clinical practice and shaping health policy in nephrology worldwide. So Marcello, the floor is yours.
Good afternoon, and thank you so much for the introduction, Dr. Mikkelsen. Great to see you again. I'm so proud to be part of this coalition. It's a partnership that brings together our society, the International Society of Nephrology, the World Heart Federation, the International Diabetes Federation, and so many other organizations. All of us are united, as you alluded to, by the shared conviction that circulatory health is where the NCD agenda will be won or lost. And I'd like to thank all of our partners and for all of our viewers for the commitment to this work. As Dr. Mikkelsen alluded to, 2025 was a landmark year. The political declaration gave renewed momentum to circulatory health. And as Dr. Mikkelsen mentioned, thanks to leadership from Guatemala and others, at the World Health Assembly, we saw the adoption of the first ever resolution on kidney health. These are both really important milestones. But resolutions and declarations, as we all know, don't improve outcomes on their own. And what matters is whether we're able to seize their opportunity to change priorities, investment, and delivery of healthcare at country level. For all of us, it's clear that to meet the ambitious reductions in mortality that are required by the SDG target 3.4, none of us can continue with business as usual. Circulatory conditions like cardiovascular disease, diabetes, and kidney disease together account for the largest share of premature NCD mortality. Because they share common risk factors, care pathways, and effective treatments, we can no longer continue to treat them as separate problems, each of which is dealt with in its own silo. Our continued dealing in this siloed manner is one reason that progress towards the goals has been slower than expected. But there are solutions, and in fact, SDG Target 3.8 reminds us of the importance of health systems for closing the gaps. The solution lies in robust universal health care packages that offer financial risk protection, access to high-quality healthcare, and availability of effective and cost-effective medications. Primary healthcare is a delivery platform that connects these two goals. Early detection, integrated care that isn't siloed by specialty or organ system, and patient-centered management of comorbidity and multimorbidity are all best delivered in primary healthcare. If we look back compared to where we were after earlier high-level meetings, today there's clear alignment around integrated NCD care, stronger emphasis on primary care, and greater recognition that circulatory health, what we're here to talk about today, is the practical entry point for system reform. Today's discussion will be about translation and implementation. What does the declaration actually commit governments to do? How will we measure our progress towards implementation? And what kind of health system transformation is required to turn commitments into reality? We'll start by exploring why circulatory health matters so much to the NCD agenda and why integrated primary care is central to delivering on these commitments. I'll now pass back to Dr. Mickelson. Thank you.
Thank you. Thank you very much, Marcelo. It was so good to hear you and your warm welcome and for the setting the scene. So you have highlighted why the moment matters and why strong leadership and partnership across disciplines are essential if we are going to turn the global commitments into real progress. So we will now move into our first segment of circulatory health insights, commitments, gaps, and opportunities, and why the UN political declaration matters. In this segment, we will examine why circulatory health must be at the center of national NCD responses, the opportunity of the declaration, what it represents, and where the critical gaps remain. So Marcelo, I would like to invite you again to stay with us and share your reflection on these issues from the ISN perspective. So the floor is yours again.
Well, thanks so much. So as we all know, cardiovascular disease, diabetes, and of course, kidney disease together account for a large share of premature mortality, disability, and healthcare utilization. But in clinical practice, they present not as isolated conditions, but as multimorbidity. And if we think about that framework, it's where the patient is the center of the care system. The patient has several overlapping conditions, and they must be managed together. Whereas in contrast, the system is increasingly organized around organ by organ care. We need to change that and provide whole person care, which is what the patients need. Kidney disease affects more than 850 million people globally, and it's tightly linked to both cardiovascular disease and diabetes. But because kidney disease progresses silently, and because it often remains unrecognized and undiagnosed until its advanced stages, cheap and effective treatments often remain unused until it's too late. This missed opportunity around the world costs lives, wastes money, and perpetuates inequity, especially in low and middle-income countries. We know that kidney disease and all other circulatory conditions must be addressed earlier in an integrated manner that deliberately breaks down silos and which leverages the strengths and opportunities of primary healthcare. It's in primary healthcare that risk factors can be identified, clinical conditions can be managed, where we can build pathways to support continuity of care, and where we can focus on person-centered management of comorbidity. What we currently have, which is fragmented, often vertical, often disease-specific approaches, what we currently have works against that goal. The 2025 political declaration places clear emphasis where it belongs, which is on strengthening primary health care and on ensuring access to affordable, effective, evidence-based drugs and devices for NCD care. There's a strong clinical logic behind this, but there's also a very strong economic logic. Early detection and timely management are relatively low cost, but advanced complications, including kidney failure, are not. If we can delay progression and avoid complications, we will support progress towards SDG 3.4 and SDG 3.8. We'll reduce premature mortality and will provide financial risk protection. We'll be able to save lives and save money at the same time. In May of 2025, as we've already mentioned a couple of times, the World Health Assembly adopted the first ever resolution on kidney health. This is significant because the resolution explicitly does not create a new vertical priority, but rather it supports the coalition's shared goals. It formally anchors kidney disease within national NCD agendas, and it reinforces the case for integration. From the perspective of the International Society of Nephrology, the question now is how can we best support countries in implementing the resolution's commitments? Our goal is to help countries to integrate kidney disease into existing primary care, NCD, and UHC programs, and not to create new parallel programs. Success will require 4 key early steps. First, countries should identify a focal point in government that will transcend the political cycle. Second, they should ideally establish a national steering committee that's clinically led and includes representation from all of the circulatory health disciplines. Third, countries should do an honest situational assessment that identifies gaps, barriers, opportunities, and priorities. And fourth, they should use the situational assessment to develop a national kidney strategy that provides a blueprint for action in line with each country's priorities. The ISN is currently developing an operational framework to support this work. The intent is to provide a practical tool that helps countries strengthen early detection, risk management, and long-term kidney care within primary health care, and in alignment with broader circulatory health strategies and with the goals of our coalition. We'll be sharing more detail on that in due course, and we look forward to working with you on that. I'd like to highlight that none of this will work unless the people most effective are part of the design. Policies that are developed without meaningful input from patients and communities will not be effective, will not meet the need. And that is why we'll hear later in this session today from people who are directly affected by these health conditions. In the remainder of our session today, you'll hear a complementary perspective from diabetes and cardiovascular health leaders, and then from government stakeholders about what it will take to turn these commitments into action at country level. Circulatory health is where the NCD agenda will succeed or fail, and together, our coalition has the tools and the partnerships to make sure it succeeds. Thank you very much, and Dr. Mickelson, back to you.
Thank you very much, Marcelo, and for sharing the insight and also helping us to understand the importance of the resolution. And I'm so happy that you said that this is not a new silo. This is really us working together in a very integrated way. But you also stress the fact that it is a race against the time, and it's only a few years remaining until the 2030 target. So the declaration has to serve as a catalyst, as you said as well. I'm also very happy that you mentioned more of the sustainable development goals, because of course, I think all of us know very well the 3.4, which is specifically on NCD, but also the 3.8, and also that you stated the engine of the whole system, namely the primary healthcare system that now needs to be in place, and that the community perspective needs to be there. And also that you mentioned something that we will come back to in this webinar, the need to co-create with the people with lived experience. So I was very inspired. Thank you so much. And building on this, we are now going to have the perspective from the diabetes community point of view. So it is my pleasure to introduce Professor Peter Schwartz, which is the president of the International Diabetes Federation and a global authority in diabetes prevention and care. He is internationally recognized for his research on type 2 diabetes prevention and care. And he's also, of course, advancing innovative approaches, including digital tools to strengthen prevention and treatment worldwide. So he has a recorded message. Peter will explain why diabetes must be central to national circulatory health strategies. And with that, Peter, over to you.
Thank you very much, Dr. Bente, for the very kind introduction. I also would like to warmly thank our partners from the World Heart Federation, the International Society of Nephrology, and all the members of the Global Coalition for Circulatory Health for convening this important conversation. Together, we are showing the strength of a truly united health community, and this is important. To everyone joining us today, thank you for your commitment. This discussion is both timely and essential. The 2025 UN Political Declaration on Non-Communicable Diseases sends a very clear message. NCDs remain one of the greatest global health challenges of our time. At the International Diabetes Federation, we welcome this renewed political commitment, the emphasis on prevention, early detection, people-centered care, stronger primary health systems, and accountability. Without measurement, there can be no real progress. We also appreciate the recognition that progress so far has been too slow. But we must be honest, declarations do not change lives. Implementation does. For the hundreds of millions of people living with diabetes, heart disease, kidney disease, and other circulatory conditions, what matters is the quality of care they receive every day in their communities. This declaration gives us both an opportunity and a responsibility to turn political ambition into real impact. Circulatory health is the most urgent NCD challenge. Circulatory conditions account for the largest share of NCDs, death, and disability worldwide. Diabetes lies in the center of this emergency. It increases the risk of heart disease and kidney failure, and is also worsened by both. Too often, people living with these conditions face fragmented care, repeated hospital visits, high costs, and avoidable suffering. If we want to reduce premature mortality, address multimorbidity, and close equity gaps, we must start with circulatory health. The key question now is how to translate this declaration into meaningful change. At IDF, we firmly believe that integrated primary care is one of the most effective and cost-effective ways to do so. Primary care is where prevention becomes possible, where conditions are detected early, and where continuity of care becomes a reality. Integrated primary care means treating the whole person, not isolated conditions, one coordinated pathway for diabetes, heart, and kidney health. It means multidisciplinary teams supported through training, clinical guidelines, essential medicines, reliable diagnostics, and modern digital tools. And we know this approach works. It improves outcome and well-being, reduces costs, and strengthens health system resilience. This is not only good medicine, it's a human right, and it is also good policy and good economics. The political declaration gives us direction, and circulatory health gives us focus. Integrated primary care gives us the engine to deliver change. But successes will require courage, the courage to invest, to reform, and to put people at the center of every decision. As we move forward, IDF calls on governments and partners to embed circulatory health into national NCD and UHC strategies. Measure what matters: detection, treatment, and control. Guarantee access to essential medicines, insulin, and technologies. And meaningful involve people living with NCDs in shaping solutions, because policy designed without people will never fully work for people. The political declaration has opened a door, actually a wide door. Let us ensure that we look back in 2030, we can say this was the moment when commitments became action and when millions of lives began to change for the better. The International Diabetes Federation stands ready to work with all of you to make this vision a reality. I thank you very much for your enthusiasm, your commitment, and your focus on preventing NCDs for millions of people living with NCDs worldwide.
Thank you so very much, Peter, for your thoughtful and very energetic reflection. So the political declaration indeed sends an important political signal. It is implementation that will shape whether lives actually change. And you're rightly highlighted that people with lived experience, living with diabetes and other circulatory conditions, they need to be at the table and they need to tell us what matters the most in quality, continuity, and affordability of care. And most of you must have seen a couple of recent, very scary publications as well in the field of diabetes. First of all, a recent study from Ghana on how the out-of-pocket payment is more the rule than the special occasion. So actually the people who wants to have access to care has to pay out of their own pocket. And also the last Nature publication, which was about the global macroeconomic burden of disease, was absolutely crazy stunning. It tells us how many trillions and how huge part of the GDP is actually lost because of lack of continuity of care of people with diabetes. So you raised all of this as well, the fragmented and disease-specific approaches that are no longer fit for purpose and that integrated primary health care must be the foundation. And this brings us directly over to cardiovascular care and health and prevention and the cardiovascular dimension and to the priorities of the heart health community. And it's now my true pleasure as well to introduce my friend and my president in the World Heart Federation, Professor Jagat Narula. And he is globally recognized as a leader in cardiovascular medicine and research. Jagat has been at the forefront on advancing equitable access to prevention, diagnosis, treatment, and care for cardiovascular diseases. And he has a special interest as well in neglected heart diseases. So Jagat, the floor is yours.
Thank you, dear Bente, for the kind introduction. And thank you, Marcelo and Peter, for your leadership in moving the political declaration forward. I would also like to thank International Society of Nephrology, International Diabetes Federation, and the wider global coalition for the circulatory health for co-organizing this very important and timely webinar. Exactly 5 months ago, the world gathered in New York for the 4th United Nations high-level meeting on non-communicable diseases. The resulting political declaration adopted in December 2025 is now the definitive framework for our mission through 2030. But must we be clear? A declaration is not an endpoint. It is a beginning. It's a map. And above all, it's a moral contract between governments and their citizens. At the World Heart Federation, we strongly welcome this renewed political commitment, particularly the emphasis on prevention, early detection, people-centered care, stronger primary health systems, and accountability. The 2025 political declaration is especially significant because it firmly anchors circulatory health within a framework of integration. Crucially, the declaration includes clear, time bound targets, most notably, the commitment to ensure that at least 150 million more people would achieve controlled hypertension by 2030. But we all know commitments on paper only matter if they translate into real world impact. This is equally true for circulatory health. Circulatory conditions have inflicted persistently the largest and fastest growing non communicable disease burden globally. They account for the most non-communicable disease-related deaths, feed into other NCDs through shared risk factors, and disproportionately affect the low and middle income countries. The epicenter of the NCD burden, the cardiovascular diseases are responsible for more than 20 million lives lost each year, closely intertwined with diabetes and kidney disease through shared metabolic, environmental, and socio-economic risks. It is one of the greatest tragedies of our time that even though 80% of the cardiovascular diseases may be preventable, millions still die, rendering this not only a health failure, but a policy failure. For the World Heart Federation, the 2025 political declaration marks a historic milestone. The question now is how we effectively implement it. And from WHF perspective, that implementation hinges on five core priorities. First, scale up hypertension control. We insist we must reach 500 million more people with treatment by 2030 to help achieve 50% blood pressure control globally. Hypertension remains widely undiagnosed and uncontrolled, and expanding primary healthcare based screening, treatment, and follow up is one of the most cost effective ways to prevent cardiovascular disease. Second, implement fiscal policies, at least 50% taxation on tobacco, alcohol, and sugar sweetened beverages that would ensure reduced consumption, save lives, and generate sustainable revenue for health systems. Third, adopting and implementing the WHO 2021 Global Air Quality Guidelines. Air pollution was responsible for approximately 8 million premature deaths in 2023, with half resulting from heart disease and stroke. Clear national targets and monitoring systems can significantly reduce this burden. Fourth, address systemic inequitable distribution of healthcare and establish sustainable financing structure for cardiovascular health promotion and disease management. Countries must expand access to prevention, diagnosis, and treatment for cardiovascular diseases and other NCDs within universal health coverage while increasing domestic health spending and developmental assistance, particularly in low and middle income countries. And finally, commit to a 50% reduction in NCD related deaths and disability across all age groups by 2050. This requires not only to limit focus on adults, but to expanding SDG 3.4 to include children, adolescents, and old, and incorporating morbidity into global targets and monitoring frameworks. Taken together, these five priorities are mutually reinforcing and generate collateral benefits across circulatory conditions. And what links all these priorities and allows synergies to translate into real world impact is integrated primary care. It is where circulatory conditions are prevented, detected, and managed. This is where hypertension is detected and controlled, where diabetes and kidney disease are dealt with, where prevention and long-term care are connected, and where all populations are addressed most effectively and equally. It is also where limited resources deliver the greatest return on investment. According to WHO estimates, investments in CVD management yield an average return of $8 for every $1 invested. To catalyze change, must we master the policy levers that create healthy environments. whether advocating for walkable cities to reduce physical inactivity or front of pack labeling to lower sodium intake. There are avenues that help move the needle. The World Heart Federation plays a bridging role here, connects the clinical expertise of our members with the political will of the governments. As we look forward to 2030, the window of opportunity is narrowing. The 2025 political declaration has given us the mandate, but the force of change must come from within us. Circulatory health offers one of the strongest returns on action within the NCD agenda. With political commitment, small fiscal policies, clean air, sustainable financing, and strong primary care systems, we could move from declaration to delivery and from fragmented responses to lasting impact. The World Heart Federation stands ready to do its share, working with governments and partners to turn this ambition into measurable gains for cardiovascular and circulatory health worldwide. Thank you all for joining hands and working together. And back to you, Bente. Thank you.
Thank you very much, Jagat, for such clear messages. I am extremely proud, and I think it's allowed to be that as part of this global coalition of circulatory health, that we are so clear on the targets. And you articulated that this declaration is a framework, but we need to have strong targets. We need to create the roadmaps, and we need to be very, very clear and repeat our messages. And you have also told us that it is possible with a high return of investment. So thank you very much, Jagat, for these very strong words. And again, thank you, Marcelo and Peter and Jagat, for your insights. Your main message is very clear, and it is about circulatory health and how these diagnosis and conditions are actually offering the strongest return of action within the NCD agenda. I would like to add that this is not a choice, it's not a hobby, it's actually a commitment that we need to be accountable for. So when we talk about accountability and urgency, there is no other actor in this big jigsaw than the government. The government is, as we know, the most important. And we can also remind ourselves that when we have a political declaration, this is actually a commitment at the heads of state and government level. So we have strong commitments. And now we are very, very happy to have with us today Dr. Stephen Mutiso. And he will give us a perspective from the African region, where the burden of circulatory condition continues to rise very rapidly. So it is my pleasure to introduce you, Dr. Stephen Mutiso. You're chair of the Cardiometabolic and Renal Health Technical Working Group, as well as the lead of the renal program in the Division of Non-Communicable Diseases at the Ministry of Health of Kenya. Dr. Mutiso brings extensive experience in advancing kidney health, strengthening NCD programs, and integration of prevention and care into primary health care systems in Kenya. We really look forward to listen to you. Dr. Mutiso, over to you.
Thank you very much, Bente. Dr. Bente, it is indeed a pleasure to be on this forum, and I'd like to express my thanks to the organizers, to Professor Marcelo Tonelli and the team at the ISN, to Peter Schwartz at IDF, and also to Professor Jagat Narula, as well as all the other panelists that we are sitting on this very auspicious day to discuss matters circulatory health. Perhaps I should start by just mentioning that indeed in Kenya, and we are within the East African region and a lower middle income country, there cannot be a more timely moment for this kind of declaration. And it actually augurs well for circulatory health. And I think I'll just jump straight into it. It's more an implementation of these resolutions conversation for me, and I think I just want to highlight some of the situations that have arisen prior to and during the declaration and even afterwards. And I just remember a conversation I was having with Professor Tonelli, and the 4 points that he raised is that first, you need a focal person in government, and I was like, good, we tick that box. Second, we need a steering committee. And fortunately, we formed a cardiometabolic and renal health technical working group that brings in all these disease entities, and more importantly, still also has good representation from the patient societies, and also includes mental health representation, which I feel is a very strong part of patient-centric care, especially for chronic disease. We haven't yet gotten to the assessment, let's say, for chronic kidney disease, but we do have a strategy, the NCD strategic plan for the country, and we're actually about to embark on writing the next phase that will cover us through the 2030 period. So what does it mean? What does it portend for governments? So I think with every political sort of statements and declarations, you must get political support within country. And in Kenya, we're very fortunate. Since 2023, it has been an agenda of the government to deliver universal health coverage. And in so doing, we're able to have a very conducive environment for us to, start to program around preventive and promotive healthcare versus curative models that we have been struggling with implementing. So I think the key thing is that we managed to get really strong support from the political elements and from the executive, and we managed to get 4 very strong healthcare acts that are really tuned towards universal health coverage. And the first one actually is the Primary Healthcare Fund Act, and this actually governs how primary healthcare will be delivered. And this is, I think, one of the most powerful ways of securing domestic finance at the primary healthcare level, because all revenues that transact at that level will be retained within those facilities to sustain care. And then, of course, to support that, we had a Facility Improvement Financing Act to sort of ring-fence that kind of process. A very key act for these 2 processes to come into play was the Social Health Insurance Act. And this actually develops what we call the Social Health Authority to manage these kind of funds. And it's not only just manages the authority, not just the primary healthcare fund, but also the social health insurance fund, which takes care of care at the higher levels. So more specialized care, things to do with maybe heart transplants, or even more recently, we've fully onboarded renal transplantation procedures, both for the donor and the recipient, as well as lifelong post-transplant care taken care of by this social health insurance fund, as well as an emergency, critical, and chronic illness fund that looks at the more critical aspects as well as parts of the chronic disease elements of care. So now we have secured some form of financing, of course, through these milestone acts. Of course, we do have quite a bit of support in some of the elements Professor Jagat has mentioned. So we're looking at the sin tax spaces on tobacco and alcohol becoming more vibrant. We have sugar-sweetened beverages. Legislation in that space is coming up. So now that we have secured some of the domestic financing, the next part of the plan is, okay, fine. So where do we go from here? How do we start to integrate circulatory health into the primary healthcare space now that we have the legal frameworks for this? So like I mentioned, one of the very first things is we are really moving into a preventive and promotive health space. And one of the key things in this space is that we do recognize that primary healthcare is the vehicle to us achieving universal health coverage. So we have about 315 primary healthcare networks in Kenya currently. And they do have multidisciplinary teams, and these primary healthcare networks run on a hub and spoke model. So the primary healthcare level that runs from the community and the dispensaries and health centers at the lower level form part of the spokes, and the hub, of course, is the next third level, third tier hospital. And these are where we are focusing all our activities on. And interestingly, we also have this wonderful community level, where we have community health promoters, of course, not medics, but trained in some of the basics of sort of care. And we have modules for NCDs that community health promoters or CHPs are trained on, and they are really the tip of the spear when it comes to screening for diabetes, screening for hypertension, awareness, wellness, and those kind of spaces within the communities. And then, of course, we have the cardiometabolic and renal health technical working group, which is more or less the steering committee that Professor Marcelo was referring to. And of course, we do incorporate both in the multidisciplinary teams and in the technical working group, the mental health components. So currently, we are able to deliver some kind of structure that fits within the legal framework. But then comes the question of quality of care. And how do we make this care-centric? I think this journey for us started around the conversations in Guatemala, and also we had a little bit of a push in the right direction with the support we get from a lot of the mentors in the space. And eventually we ended up with the World Health Assembly 78 resolutions that eventually lead to this wonderful UN declaration. But all these need to be translated, and they need to be broken down into sort of elements we can consume. So one of the key things is that we look for the WHO best buys. We look at the package for essential NCD interventions and PEN Plus as well, which is already started off in Kenya. Disease control priorities has been a very strong document that we use to sort of customize UHC interventions for lower middle income countries at the primary healthcare level. And so we keep having this wonderful translational science space that we try and get these interventions fit to purpose for the purpose of standardizing the care pathways. So we want to have guidelines that are both globally competitive, but also meet the needs of the people where we are, and particularly in the primary healthcare space. So I think that pretty much sums up what we are trying to put together and wrap up for the circulatory health space. And thank you, and back to you, Bente.
No, thank you very much, Dr. Matuso, and for sharing what you do in Kenya. And I have to say, warm congratulations, both on the legal side, but even more impressive that you have actually secured domestic funding. I think we all understand that there is no way around that. We all need to have a social insurance system to achieve UHC. So this is very, very inspiring. And also, you mentioned the hub and spoke and the community care workers. So I think you have laid out your own framework, and you were ending up talking about the quality of care and equity. And of course, these are questions that we need to support each other on across national borders. But I think your experience and your commitment from the government is really, really impressive. So stay tuned, Dr. Matuso. I'm sure there will be questions for you as we move forward in the program. Thank you very, very much. So we will now move to our panel discussion. And what we want to do is to unpack the political declaration. So what it includes, what needs to happen to implement, also to, again, continue to focus on circulatory health. And in this segment, we will listen to many different perspectives, from the UN system to the civil society, technical expert, and people with lived experience. And we hope that you will also provide some questions in the Q&A that is, you can see it on the lower part of your screen. We will try to answer some of the questions as we move, and some of you have also sent us questions before the webinar, so we will try to pick them up as we move into the final discussion. But before that, it's my true pleasure to introduce the panel. So first, we are joined by Dr. Nick Banatwala. He's the head of the Secretariat of the UN Interagency Task Force on NCD. And he's also a good friend. He brings extensive experience from global public health over many, many years, and also on development cooperation and cross-UN influence and opportunities and public health leadership. We will also be joined by Dr. Kim Yu. an executive family physician leader and a board member of the World Organization of Family Doctors called WONCA. And Kim, you served as WONCA's liaison to the World Health Organization, and is a strong advocate for primary health care, health equity, and leadership development. From the lived experience community, we welcome Mrs. Dani Mochi, Chief Executive Officer of the International Alliance of Patients Organizations. Dani led the first global alliance uniting patients organizations across disease areas and brings strong focus on empowerment, equity, and community-centered solutions. And finally, we are very pleased to have Mr. Howard Cotton, Chief Executive Officer of the International Council of Nurses. Under his leadership, ICN effectively represents nursing worldwide, advancing nursing profession, leads global advocacy on the nursing workforce, and champion the central role of nurses in health system delivery and policymaking. So if we could, we should applaud our panel. So I will ask some questions, and the panelists know the questions before we start. So we will try to make this a little bit interactive. So I will ask you, Nick, to open your camera so we can see you. Maybe we can see you. I cannot see you. But I hope
I hope.
Yes, great. I see you, Nick.
Excellent.
That's great. Great. So I would like to start with one question that actually many people ask themselves, because we have a political declaration. But the question is, what kind of mechanisms and tools do we have to monitor and track the implementation of these commitments, both in the area of policy and also more precisely on health system strengthening, giving the non-binding nature, as we both know? So it's not an easy one, Nick, but I'm sure you know the answer.
Well, thanks a lot, Benta, and it's really good to see you here, and thanks so much for this moderation. Thank you for everyone for inviting me to be here. I want to come back to your first comment that you made earlier, and then we've heard from Kenya as well. This is about national and country level action. And so we can talk, and I will say a bit about things at the global level, but what I really want to highlight is that actually the monitoring needs to be done at the country level, because at the end of the day, regional and global monitoring depends on the data that are collected at that level. And we've also talked a bit about the fact that we don't want to see this in silos. So therefore, I'm coming back to thinking about something we haven't really talked about, which is NCD strategies, national NCD strategies, national multi-sectoral NCD strategies. And they often include monitoring frameworks in there. And these strategies, how important it is that they are costed, how important it is clear on who's delivering on what, and then that the monitoring tools make some sense, that we're not trying to monitor 452 different elements, but we've got a small number of things that we're going to be moving forward. And of course, countries have got to determine that themselves. I don't think we should apologise that this is non-binding, and indeed I don't think we should really even say that to anybody. As far as I'm concerned, this was adopted by the UN system, and we've got our marching orders, and if anyone wants to come back and challenge us about the binding, I'm not interested in that discussion, I would say. We are going to just move forward on this, because after all, at the global level, we're going to be coming back in 2031, which isn't so far off, and we're going to have to show and demonstrate progress. So fine, non-binding, you come back and say that in a few years' time, and it's not going to feel too good. But let's just think a bit about circulatory disease, because many of you will be aware of the WHO Heart Technical Package that aligns with WHO PEN Package of Essential Non-Communicable Disease Interventions. And in there is parts, each one stands for a letter, and the S stands for the surveillance aspect. And in there are some pretty compelling indicators that countries should be using. So if anyone is thinking, well, so what am I going to measure? What am I going to monitor? What am I going to try and put into our our NCD strategies, have a good look at that, because the suggested list of indicators are included in that module. At the global level, my colleagues here in WHO will be updating the global monitoring framework, and will clearly be looking at cardiovascular disease, and they plan to do that between now and the World Health Assembly for next year. So that's important for people to be contributing to, and like all these things, it will be an opportunity for collaborative discussion to get to a final agreed framework. But also remember that under the Economic and Social Council, there are the annual high-level political forums that come through, and that's another opportunity of following on at the global level. I've mentioned 2031, which will be the key next high-level meeting. So I think that we've got a number of key events, and of course every year the World Health Assembly does put in a report, or I should say the World Health Organization Secretariat puts in a report into the World Health Assembly where we take stock of progress today. But I come back to the fact that doesn't matter how nice we try to make our global reports, it depends on the quality of those data. And I don't want to use that trite phrase, so why am I going to use it? That trite phrase that what gets measured gets done, but someone had to say it, so I said it. Back to you, Gunther.
Thank you very much, Nick, and I'm so happy that you mentioned, that you basically don't care, that it's non-binding, and I think we should absolutely ignore that kind of discussion, because as I also mentioned, I mean, it is really the heads of states and government that commit. I cannot think about any stronger commitment. And I'm actually happy that not all commitments are legal. I think it's very good that we have the flexibility, as you say, that we can really look at each national plan, each country, and see how they want to implement and measure. And thank you also for mentioning the HEART package and the PEN, and that we will have a new updated global monitoring framework. And I think for all the friends on this call, we have all the role to play. We need to encourage the governments, we need to help them as civil society to really report back on all these different things in a very truthful manner, because that's actually a way for all of us to also support in the next step. So you came into, some of the things we wanted to ask you, because we also wanted to ask you what is the 3-4 high impact national actions that you would recommend, and you have recommended already the HEARTs. I don't know if you want to add something to that question.
Yeah, what I thought might be interesting is I could mention 3, and there are so many different ones, but I thought it is well worth just taking a step back, and it was highlighted right at the beginning, that we have to think of NCDs in the round, and indeed universal health coverage in the round, and not just on circulatory health. It's kind of interesting that most people who've got an interest in an issue will take a document, a PDF, and they'll quickly do a word search, and they'll count how many times they see their magical word there. If you put in circulatory health, you get a big fat 0. But when you do cardiovascular, you get 8 in total, and they are there in a couple of paragraphs. If anyone wants to look, they're paragraphs 49 and 50, which account for 5 out of them. But what I think is interesting is for people to think about the 5 key areas of the political declaration. And I don't have time to go through each and every element of them, but let's just remind ourselves on what those headline issues are. It's about health promoting environment through action across governments. That's number 1. And you can think immediately of all the different issues that would be related to cardiovascular disease, circulatory health. Strengthening primary healthcare, we've heard a lot about that. You can't do anything without adequate resources. So mobilizing adequate and sustainable financing is the 3rd key area. And then strengthening governance, absolutely critical. And I'm always asking myself, well, where do parliamentarians fit into this? And we may come back to that a little bit later. And then supporting research and data and surveillance, as I've mentioned. So there are kind of 5 key issues. And so I will give my 3 or 4 top issues, but I feel nervous in doing that because I think actually, if you go through each of those areas and the different actions underneath them, whether they're around health taxes or around supply chains, or they're around multi-sectoral action plans. They're all written there and they've all got relevance for circulatory health. But look, I'm going to mention a few. Implementing hearts. We've now said that enough times, but we've said it again. I think strengthening population level tobacco control. Eliminating trans fats. Now I'm nervous because someone talked about pollution and air pollution, and yes, that's in there, but I'm sorry it wasn't in my list. And then I do think it's just worth us reminding ourselves about the obesity challenge and the recent WHO guidance on GLP-1 agonists. And it's not a golden magic bullet, but it's an important tool alongside the broader WHO acceleration plan to stop obesity. So there are some thoughts.
Thank you. And of course, hypertension is key in hearts. So you mentioned it, but
Yeah,
don't
absolutely.
mention it.
Yes.
Yeah. So my last question is, coming back to your role as head of the UN Interagency Task Force. So how do you see the UN Interagency Task Force can support the circulatory health and, maybe more broadly as well, the implementation of the political declaration?
So briefly, a couple of thoughts. First of all, civil society does have an important opportunity in delivering services, but it must be under the leadership of government, and government has to take responsibility. But we see many civil society organizations that actually do deliver incredibly valuable services. But what I want to focus on here is about holding governments to account in those areas that I described earlier, those 5 areas. And that's absolutely critical. And I just want to highlight 2 examples that I think are really important. The first is civil society, people with lived experience, professional societies engaging with the media. I would like to see so much more investigative journalism. Too often we get journalism that simply says another health centre has been opened, a Minister of Health has gone somewhere and cut a ribbon, how fantastic that is, rather than trying to dig deep into some of the issues and say, well, you've got a person who is no longer on their treatment because of stockouts or because they've got a shortage of healthcare workers, and trying to explore that. And the second area I'd like to think about is the issue about engaging with parliamentarians, because I think that's really important, and reminding ourselves that parliamentarians are our voice in a democratic system. So we ought to be using those. I am reminded of that quote from over 75 years ago, 77 I think it is now, from Anira Bevan, who was considered to be the founder of the NHS in the UK. And he's often credited with the saying, if a bedpan is dropped on a hospital floor, I want the noise to reverberate around the corridors of the Palace of Westminster, which is the House of Parliament. And I think that's kind of important, that actually at the end of the day, it's really key that parliamentarians and government are accountable for delivering on health and healthcare and this political declaration.
Thank you. Very strong words there in the end, Nick. And I might come back to you, but thank you so far. So we will now turn to Ms. Dani Mochi. So if you can open your camera, and from your perspective, are you there?
Yes.
Great. Good to see you. Big smile. Good. So from your perspective, what are the most important priorities for achieving better circulatory health and more integrated care through primary health care service?
Firstly, it's a pleasure to be here and join you all today. And without a doubt, this political declaration on NCDs is a milestone and a big opportunity for us all. But I think for millions of people with living with an NCD, and more specifically with a heart disease, diabetes, or kidney disease, the question is very simple. Will this declaration really change the care that I get? And that's the lens that IAPL brings to these discussions, the perspective of those people who are navigating the health systems every single day. And I'm going to talk about very quickly about 5 priorities. At the front, the most important one is the meaningful engagement of people with lived experience in how care is designed and delivered. So when governments translate this declaration into national strategies or adapt their existing ones, us, people with lived experience, patient organizations, we have to be part of the decisions shaping the implementation of these strategies and plans, because our knowledge is irreplaceable. It's grounded in managing our conditions around the clock and navigating the health systems. So we know what works and what doesn't because we are there living it every day. We need to break down the silos. We heard this before here. A person living with diabetes, hypertension, and early stage kidney disease doesn't experience 3 separate conditions. They experience one life, one body. But yet too often, health systems treat them as 3 different patients, and they access disconnected care pathways. So primary care must be integrated and reflect how people actually live with those conditions. Another key point is access and affordability. We can design the most sophisticated care model in the world, but if people can't afford medicines, can't access diagnostics, or can't reach follow-up care, it fails. So this is about equity. Circulatory conditions hit hardest where resources are scarcest. And I'm talking about low and middle income countries, rural communities, women, non-white populations. So if we are serious about this declaration, our postcode, income, gender must not decide whether we live or die from a preventable condition. And equity, because of that, equity is not an add-on, it's the foundation of these discussions. Early detection, the 4th priority. Too many people are diagnosed only after they go experience a heart attack or after diabetes has caused irreversible harm. And this happens most where primary care is weakest. We heard also this here before. No screening, no routine checks, no follow-ups, and this cannot carry on. So primary care needs the tools, training, protocols to detect early the diseases. Prevention and early detection saves lives and they save money as well. And it's an incredible way to reduce an inequity. And finally, the 5th priority that I want to highlight is health literacy and self-management. People with lived experience manage their health 24/7 and see a doctor only a few times a year. That makes them the most important health worker in their life themselves. But they need knowledge, confidence, support, and health literacy isn't just a nice to have. It's a nice to have, sorry. It's the foundation of long-term care. And with the right information, support, people become agents of their own health and advocates as well, as my fellow advocates in our global patient community. We need really to create information that it's culturally appropriate. This is key when we talk about equity as well in local languages and delivered in ways that really reach people. We need to meet people where they are. So again, 5 priorities: meaningful engagement of people with lived experience in how care is designed and delivered, breaking down the silos, access and affordability, early education and health literacy, and self-management.
Fabulous. And I was about to repeat them, but you did it yourself. Thank you so much. And I am especially happy that you also mentioned health literacy and self-care, because that's very often forgotten. I think as a last part of my question to you is, if global commitments succeed, what is the most significant change in your day-to-day management of your condition you would expect to see in the next 3 to 5 years? I mean, what is your dream, let's say? I mean, of course, all your 5 priorities, but if you could put it in a different way, for you as a person, what would you mention?
I think the change I want to see is simple but very transformative. That no one, regardless where they live, how much they earn, or what language they speak, should have to navigate a fragmented health system alone. It's enough. I think I would hope that a person with lived experience anywhere in the world can walk into their primary health service and access coordinated, affordable, continuous care and feel genuinely supported, feel seen, feel like the system was designed with them and not despite them. That's not just a health system improvement, in my opinion. That's about health equity. It's about human rights as well. And I think the declaration gives us that mandate, but now it's on all of us to shape this together, to hold everyone accountable and monitor and follow the implementation of this declaration.
Thank you very much. I think that's a beautiful way of putting it. No one should be alone, and there should be support and a transparency on how to get it as well. Thank you very much, Danny. I will now turn to Dr. Kim Yu. So please open your camera. And my question to you is, what are the most practical, necessary steps primary care facility must take to fully integrate the prevention, early detection, and timely management of cardiovascular diabetes and kidney disease? So I don't know, Dr. Kim Yu, if you are there. I still see.
Can you
Danny?
see me?
Yes, now I see you. Very good.
Okay, great. Thank you so much for the invitation to Wonka to speak on this esteemed panel. And just a little bit of framing for those that don't know us, Wonka represents over 500,000 family doctors worldwide. And when we talk about NCDs, we're really talking about the core of family medicine: prevention, early detection, safe long-term management, and continuity across the life course. Family doctors don't treat NCDs in isolation. We walk with individuals and families over time, which is exactly the equity and integration this declaration calls for. For cardiovascular disease, over 80 to 85% of conditions may be treated by primary care. And from another study, we know that between 88 and 90% of adults with diabetes saw a primary care clinician in the prior year. So from Wonka's perspective, the most practical steps begin with strengthening primary care itself. First, we need team-based, person-centered care models where every encounter is an opportunity for risk assessment, lifestyle counseling, and follow-up. Nurses, community, health workers, pharmacists, and family doctors must function as a coordinated unit so prevention isn't limited to the brief physician visit. Second, we must implement simple and scalable screening protocols. So we've talked about how we need to get rid of these silos, and we need to have one integrated pathway for cardiovascular, diabetes, and kidney diseases to be managed. And every appropriate visit, whether acute or planned, should include simple standardized risk checks for routine blood pressure, smoking status, BMI, lipids, A1C, kidney function. All of these should be integrated at every visit. And having validated risk stratification tools and embedding these into electronic health systems ensures consistency and reduces missed opportunities. Third, we've got to shift from episodic treatment to continuous community-anchored care. That includes proactive outreach to high-risk groups, culturally and linguistically appropriate education, and clear referral pathways that support timely intervention. Digital tools like registries, reminders, telehealth can greatly expand continuity, especially in underserved areas. And we need to, as others have mentioned, medication access needs to be affordable. And this is critical. We have to have streamlined formularies and reduced financial barriers to ensure that clinical recommendations can actually be followed. Finally, none of this is possible without supportive policy environments that invest in primary care, protect time for team training, and promote data-driven quality improvements. Systems need to also align incentives with person-centered outcomes, not disease-specific targets. Together, these steps really build a primary care system capable not only of managing chronic disease, but preventing it, advancing equity, improving population health, and embodying the values of family medicine worldwide. Indeed, no one should be left behind.
Such a wonderful answer to my first question. Actually, you managed to answer many of the things I wanted to ask you about, because you mentioned so many of the essential components, and some of them are not that often mentioned, like the risk assessment and the proactive sort of outreach to patients. So I think you touched on many things, but you mentioned that there is a need to break down silos, and that we need to integrate, and that many of the circulatory conditions often coexist. So even if we know that, Kim, many times it is difficult to really make the systemic changes that make these sort of coexisting diseases be addressed at once. Could you develop a little bit more on that specific thing? How do we make this happen when a person comes with hypertension and also with type 2 diabetes, maybe obesity? So what is your sort of last advice in this? Maybe highlighting one of the things you mentioned, or mention something else.
Sure. From our perspective, from Wonka's perspective, shifting primary care from the disease-specific model to one that truly manages multimorbidity requires system-level changes that really strengthen and enable primary healthcare teams. We know that community-based, patient-centered, multi-professional primary healthcare teams deliver coordinated, continuous preventive care that lowers mortality, disability, inequities, often at lower cost, and that continuity, just that alone with a family doctor, reduces hospitalizations, emergency visits, and unnecessary duplication. So to make this the norm rather than the exception, we need to clearly define delivery frameworks, especially in low and middle income countries, that outline what interventions are achievable and ensure the resourcing to carry them out. And these frameworks must be adaptable to local contexts, something that family doctors are specifically trained to lead. We need to also embed proactive care into routine practice. That means building those strong partnerships with patients, supporting the self-care and health literacy, addressing social determinants of health, and integrating social prescribing so patients are connected to community-based supports beyond the clinic. Ensuring those tools are available for true population health management and that they are easily integrated with electronic health records. At the same time, we must strengthen reactive care systems for patients already living with multiple chronic conditions. And family doctors need authority and support to coordinate the multidisciplinary teams, personalizing disease-specific guidelines to individual needs, and ensure care is cost-efficient and safe. This includes balancing the overuse of tests and treatments through shared decision-making and ensuring that data and electronic health records are easily accessible. Finally, the system must support modern flexible care modalities, especially high-quality telehealth, to maintain continuity and safety in our now post-pandemic world, right? And so, in short, we truly believe that the shift requires primary care systems designed around people, not diseases, powered by strong primary healthcare teams, informed by local context, and led by family doctors who can integrate prevention, management, and community partnership under one coherent approach.
Thank you very, very much. And I will remember you for continuity and delivery framework. And you mentioned so many extremely important things. And something you emphasized, maybe even more than anybody else on the call so far, was also the need for access to data and the use of data in daily life for family doctors, but also for the patients themselves. So I thank you, and we will now move to Mr. Howard Catton. I don't see you yet, but I'm sure your face will be on the screen in a second. So
I'm here, Bente.
That's great. Good to see you. And you represent such a huge amount of healthcare workers. I'm sure you will tell us afterwards. But given the shortage of physicians in many settings, and I will also say shortage of nurses, how can nursing role be optimized and expanded, do you think? Because even if it's not mentioned that clearly in the political declaration, we all know this is key. The health workforce is the key. So over to you.
Thank you so much, Bente. Great to be with you. And let me also offer my congratulations to the Global Coalition of Circulatory Health. Your example, I applaud the collaboration, partnership, and the example that you're setting. You mentioned size of the healthcare workforce, and indeed, we hear many health leaders talk about the health workforce being the backbone of our health systems. And that's with good reason. There are about 70 million healthcare workers around the world. Probably 50 million or so are healthcare professionals. And the biggest single group is nurses, coming in at currently 30 million. But we also have this really significant shortage, currently predicted by work we've done with WHO to be at around 11 million. Half of that, nearly, well, more than half, 5.8 million of those are nurses. So the backbone feels weaker and fragile than we would want it to be. And the power to really make progress on NCDs is going to be directly related to the strength of our healthcare workforce. That can always sound as though one is making an argument on behalf of the profession that you are part of or the people that you're representing. But let me just look at this a slightly different way. My profession, nursing, nurses perhaps see on average how many patients a day. In intensive care, it will be 1. In a medical surgical ward, it may be 5, 6, 7, or 8. In primary care, it could be, in aged care, it could be a lot more than that. But if you say on average 5, then that means that there are 150 million nurse-patient interactions around the world every day. Scale that up, that gives you a figure of more than 1 billion a week. The relationship, the interaction, the contact that not just nurses, but healthcare professionals have each and every single day is a massive transformational power and potential. And I don't think that we are investing sufficiently. Why not? Sometimes from a nursing profession, I don't think that perhaps the potential of nursing to really support and deliver on prevention, care, and long-term management is fully recognized. There's now a really solid academic evidence base to show that advanced and specialist nurses working with people with NCDs help people stable, keep them out of hospital, reduced emergency admissions, patient satisfaction levels are really high. Patients feel engaged as part of the discussions that they're having with the practitioner. And it may well be the nurse who is the most consistent healthcare practitioner that a patient sees over the course of a condition as well. And in remote and rural areas where access to healthcare can be very, very challenging, again, it's the nurse, it's the healthcare worker who is the most significant individual. The evidence doesn't just tell us that the interventions from nursing are care effective. We also see that there are huge cost benefits and effectiveness as well. 2, 3, 4 times the return on investment in the economic returns in terms of keeping people well. The strength of the evidence, it's not just me saying this from ICN. The most recent report that we prepared with the WHO on the state of the world's nursing makes a really strong call to nations to say, don't miss the opportunity that nurses working in advanced and specialist roles represent to deliver the types of integrated and coordinated and patient-centered care that we want to see. What isn't happening at the moment? Education is often a big miss. There aren't the career pathways supported by education, particularly continuing professional education. There are often limitations in regulation. The roles of nurses working at an advanced level are not recognized by the professional regulators. Sometimes the health systems themselves don't pay for a nurse-led service or a nurse-led intervention. And we get ourselves caught up far, far too often in interprofessional disputes around issues about prescribing or making or receiving referrals as well. There are things that the professions need to work on, but I think we also have some blind spots at a national and a global level. You said the political declaration, great, would have loved to have seen it be stronger on health workforce, but there are some important things it does say. But when one looks at the most recent WHO document on best buys for NCDs, healthcare workers, healthcare professionals are not mentioned. I think there are also some key issues that are often overlooked around the coordination role that nurses and health workers play as well. That journey that they walk with patients mean they see the gaps in the system. They hear the frustrations from patients for having to continually repeat their stories, issues with medications getting mixed up, unable to access test results or other vital patient information as well. And the trusted relationship that the nurse has with the patient not only enables a different conversation with the patient about how to manage their condition, it means that they're also in a really strong position to integrate through the coordination role that they have. So the bottom line, top line message for me is that nurse health workforce retention and empowerment, it's a fast track to capacity building for NCDs.
Thank you very much, Howard, and I totally agree with you. And I'm not that worried that health workforce was not mentioned too much in the political declaration. Of course, we all wished it would be, but at the same time, all of us, I think all the stakeholders around this call, all the stakeholders in real life at the country level, they know the importance of the health workforce. So maybe one last question, and you have to be very brief, but I think it's an important question, because even if you represent these tremendous amount of nurses, we still know that there is a need for many, many more nurses. So what would sort of be the investment, or how would you sort of guide the governments of the world in how to invest in nursing?
There's a couple of things for me. Look at the evidence. Look at the return on investment you will get through investing, the improvements in health outcomes, the ability for people then to engage in their communities, to go to work, to be active members of their communities. Look at the savings that you make through not having so much ill health within your health systems as well. I think that we've made the case in relation to patient safety and patient improvement from the evidence for a long time, but put that alongside where the economic advantages, the accelerator, the booster effect that good health has to economic growth and prosperity. And I think it changes the mindset in terms of people who are making decisions around investment in health. And the other thing that I would say, Bente, is we cannot, if we hear commitments to investment in health, we cannot relax and think the job's done. Because what I often experience from my profession is we'll hear that there's an investment, but when we then follow through where that investment has gone to, it may have gone to a building or to equipment or to drugs. It doesn't always follow that what the investment commitment then follows through into health worker, education, regulation, development, decent working conditions as well. Health workforce management issues, HR issues, health workforce planning, dreadfully dull, unsexy topics, but actually these are some of the nitty-gritty foundations that need to be in place to make sure that, you know, investments follow through and reach the people that they're intended for.
Thanks a lot. Hard-hitting arguments, I would say. Thank you very much. So as we all see, we have about sort of 5 minutes left, and I want to pay justice to the numerous questions that we have, and I will just mention some of the topics. So people are concerned, or they want to know if mental health is part of this agenda, and I think we can be very clear back that the political declaration really made the link between non-communicable disease and mental health. And also there are very interesting questions about, you know, the use of AI, the digitalization of the healthcare system, and so on. But I have used my privilege as the moderator to pick 3 questions. And one is, how could we encourage government to include people with lived experience? And Dani will be answering that. And also there is a question to Kenya, and that has to be very brief, but it's actually congratulations to Kenya to also give access to medicines. And I think Mutuso should just say 2 words on that. And the last one is, how could we encourage, you know, the parliamentarians and the government to really listen to and mobilize civil society? And Nick can kindly answer that. But you all understand this has to be very, very brief answers. So I start with you, Dani, on the people with lived experience. How can we get government to really include people with lived experience?
Oh, now it worked. I was trying to turn on my video. Can you
Yes, all good.
Yeah, good. Do you mind, Bente, to repeat the question? Sorry.
Yeah, the question is, how will we encourage government to really utilize the experience of people with lived experience? How do we get them to engage in a meaningful way? And it has to be super short, Dani.
So I will highlight the work of patient advocacy, and I'll invite the person who shared this question to reach out to us, to IAPL, and join the movement, because there are plenty of patient organizations around the world working, collaborating in different levels with governments in their countries and holding them accountable. And now we have another resolution that can support us in this advocacy work, which is the resolution on social participation in health.
Thank you very much. Okay, Stephen, could you please, it's actually a congratulation that Kenya has also managed to include access to medicines as part of all the fabulous work that you have done for circulatory health. Could you make one comment? How could that happen? What was the sort of let's say the opportunity in Kenya to also include a better access to medicine for circulatory health?
Yeah, thank you. I don't know if you can see me.
I can hear you very well. I cannot see you.
Oh, wonderful. So benefits packages, that is the one answer. So if you can finance benefits package, and the benefits package is evidence-based, like hearts. We're working on a hearts protocol for hypertension yesterday. Then access to quality medicines is going to be guaranteed. Thank you, and back to you, Bente.
Fabulous. Totally agree with you. And for those who doesn't know what that is, I'm sure somebody can put something in the chat. And this is the inroad to universal health coverage. Last question go to you, Nick. You have seen so many governments on your support from the task force. Can you also very, very briefly comment on the importance of including civil society?
I get shot down by my friends and colleagues in WHO and in other UN agencies for saying this, but I'll say it again. I always think that civil society is so important that if someone has a small amount of funds that they want to put into the system, they're best placed to try and encourage voice and accountability by putting funds into civil society, because they are the ones that can then really start engaging with parliamentarians, with government, calling people to account. So I think it's so important.
Thank you very much. And now, all of you speakers, could you please put on your camera, and they will take some pictures while I'm saying goodbyes from all of us. So please turn on your camera, all the invited speakers. So while that is happening, I would like, on the behalf of the co-host, to make a sincere gratitude to all speakers. I think this was a very lively discussion. We could have continued for hours. I hope people online has been inspired. And what I sincerely hope for is that, you know, this is not an impossible task. This is a possible task. And I think in the next few years, we need to show all the examples like we see in Kenya, like we see in Guatemala, really putting forward the kidney resolution, and all the other countries that we know is really doing their best. I think more people need to put on their camera, by the way. And I would also congratulate us, because we have seen and we recognize the political declaration as a huge step forward. And we need to celebrate, because we need to be less skeptical, more optimistic, and really utilize it and ask for and require the accountability that goes with that, and all the heads of states and government. I'm very happy that we have got so many speakers focusing on primary health care, universal health coverage, equity, health literacy, the importance of people-centered care, continuous care. I could mention a lot of things. And I think as a sort of an underlying buzz is also the importance of strong political leadership. And something that was like a red thread today was the strong accountability, the meaningful patient engagement, and also a supported and valued health workforce, as we heard so very well from our friend in ICN. So I want to end here. We are on time. I don't know if the organizers are happy with the photo. I only see myself and Nick, but that's also nice. But I hope we are among friends, all of us. And I wish you a very, very good day, night, and morning still. And I hope you enjoyed as much as I did this webinar. And good luck to all of us with the implementation of the political declaration on NCD and mental health. So thank you to the organizers, and thank you. Bye-bye.